First of all, ATTICUS was a trial that compared Apixaban versus aspirin not only in patients after embolic stroke of undetermined source, but our patients needed to exhibit additional risk factors for cardiac embolism. The ATTICUS trial was a co-production interdisciplinary trial of cardiologists. Co-PI is Tobias Geisler, friend of mine, and us neurologists. So that was Wolf Ziemann and myself. We designed the trial. So the approach was interdisciplinary, and one special point was that that all patients underwent continuous cardiac rhythm monitoring for guiding antithrombotic therapies. That means that those patients who were randomized to the aspirin arm were switched to Apixaban upon AF detection. As I just mentioned, our patients had to have an ESUS, embolic stroke of undetermined source. They had to exhibit at least one AF predictive factor, like LA dilation above 45 millimeters, spontaneous echo contrast in the left atrial appendage, or reduced flow velocity below 20 centimeters per second, atrial high rate episodes, or a Chet-Swask score of 4 or more, or alternatively a patent foramen ovale. And they had to undergo continuous cardiac rhythm monitoring during the whole study conduct. They were randomized earlier, starting from 3 days after ESUS to 28 days after ESUS, and study drug had to be initiated within this period. We had follow-up visits, and in case of AF detection by cardiac rhythm monitoring, patients received an MRI and were switched from aspirin to Apixaban in case they were randomized to the aspirin arm. Our endpoints were new ischemic lesions on MRI, and secondary endpoints were recurrent strokes, systemic embolism, myocardial infarction, death, and the composite endpoints. The difference regarding the endpoint is that we had a smaller trial, and we looked for new ischemic lesions on MRI. And those other two trials, the RE-SPECT ESUS trial and the NAVIGATE trial, they looked for clinical endpoints, but they enrolled 6,000 or 7,000 patients compared to 600 patients that we aimed for. Finally, we had to terminate the trial due to futility after 352 patients had been enrolled. The main results that we presented was that we found a positive signal within the subgroup of elderly patients above 75 years old. These patients seem to profit from a direct anticoagulation with Apixaban compared to starting with aspirin and then switching the earliest possible upon AF detection. And actually, this subgroup was also positive for beneficial effects of dabigatran in the RE-SPECT ESUS study. As an explanation for this better treatment effect, we could demonstrate that older patients or the subgroup of patients of 75 years and older had much higher AF detection rates compared to the younger patients of 75 and below. So there was a clear age dependency regarding the AF detection rate. This graph demonstrates that also within the subgroup, AF was detected in a similar rate between the two treatment arms, which renders outcome effects between the two medications more valid. When looking at the effects of aspirin versus Apixaban in younger patients, there was no treatment difference So outcome events, this is the composite endpoint, was not different between groups. Also, there was no statistically significant difference in the older patients. Nonetheless, there's a clear trend regarding beneficial effects of apixaban in elderly patients. And on the other side, we looked also at bleeding events, showing that there is no safety concern in the elderly patient.